Module 9. This week, we will be talking about psychopharmacology and how this relates to mental states. So let's begin right away because there's a lot to cover. And without spending too much time on the theory, I simply want to discuss the two main terms that we will encounter today. The first one, as I just mentioned, psychopharmacology. Okay? Or in other words, the study of the reaction and medications to mental health, how we do utilize mental health knowledge in order to help our patients via the application of medication in the realm of psychiatry, psychopharmacology, the pharmacology of psychiatry, of psychology. And within psychopharmacology, more specifically, we will be studying what? Psychotherapy on one side as support, and on the other side, pharmacodynamics. Okay, so you could say there are three main areas here. Psychopharmacology at the center, not alone, but always to support psychotherapy, in connection, in combination to psychotherapy, and psychopharmacology explained by pharmacodynamics. So this goes back to what we encountered in week 7 and 8, and prior to that, we talked about memory and perception in week 5. Why is that? Well, because still the discussion is about the role of chemistry or chemical modulation to mental health. The assumption, yet again, is that we feel a certain way because of the underlying pharmacological chemical mechanisms in our brain. This is pretty much the same as saying that there is a serotonergic or serotonin-based theory of mental health. There are chemical underpinnings to the way we feel. There are chemical underpinnings to the way we experience life in terms of traits, problems, disorders, and overall diagnosis. So psychopharmacology at the center, never alone, but always in combination to psychotherapy. I really want to stress the importance of this and the explanation of psychopharmacology in terms of psychodynamics. How each chemical, more specifically, each chemical in connection to the reception of this chemical, and then we will talk about neurotransmission on one side and receptor side on the other side, how that impacts the way a person feels before, during, and after the intervention. Now, a few more terms that I would like students to familiarize with right away, hopefully. Well, this blue marker is really strong, okay? So the other two terms I would like you to remember are agonists, okay, and antagonists, okay? Now, with these two terms, we will define the main role of specific medication to mental health. This is not the only one that we'll be talking about, respectively, the only one within agonists and the only one within antagonists, but it's the primary way to discuss how pharmacology applies to psychology, psychiatry, and mental health in general. And in these cases, there's another term that it's really the big umbrella term that I want everybody to remember. This term is ligand, okay? Which really comes from the Latin ligare, which is to bind, okay? To bind. Now, this should not be a surprise to you because in the first case from ligare, you have terms such as ligament, alloy, religion, etc., link, okay, etc., okay? On the other side, you have terms such as binding, of course, and even other German terms such as Band, that give birth to the English band as a musical band, bandera or bandiera or flag in Italian or Spanish. And so it's something that connects things. So when we think about psychopharmacology, think about ligands, the way something is bound together, and we see how that applies to the receptor side, what how a chemical does that to the receptor side. We think about link, but also link in a broader sense, link to a specific outcome, a specific reaction that is entirely connected to, you could say, both the structure and function of the chemical. And this is phenomenal to understand because this is one of the situations where you're not really picking between structure and function, if you remember what we said about the brain. Throughout the history of neuroscience, they were the ones who were more on the functional or functionalist end of the spectrum of the debate, who believe that function is the most important thing to justify and explain the way our brain processes things, is the function that determines everything else, including structure, and the other one that could view structure as the primary way to explain away all other processes. So the debate was between what happens and the shape that allows this to happen. In the case of ligands, in the case of agonists and antagonists, and partial or semi, this is brought together because the shape, the structure, the form will determine what type of outcome. And what I'm going to ask you to do is to imagine the process as it occurs. Okay? Imagine that you have a cytoplasm here and the extracellular space here. And all this structure here. So again, in this little diagram, keep in mind the connection between agonist and antagonist. So agonism occurs when a drug binds to a receptor side, and this will cause this cascade, this outcome, this response, biological response. An agonist drug, chemical, in general binds to the same place on the receptor as the substance that naturally activates the receptor, which is the endogenous agonist. Agonists that can generate a maximal response to the receptor are called full agonists. Instead, partial agonists are the ones that are able to generate a fraction of the possible response to the receptor. Don't you worry, we'll see that in brief later on today. But just to give an example, as I'm drawing these little green parts here inside the cell here, an agonist may bind to a receptor and cause a decrease in signaling at the receptor. Here, of course, we're talking about right here of the lipid bilayer. And here, let's say a competitive agonist. All right, so to continue, the general idea is that the shape will determine the effect. So let's try to magnify using a magnifying glass this area here, okay, this area here. So let's make some room now, okay. This area here will turn into different shapes. Okay. Now, let's make some more room here. Let's do option 1. Option 2. And option 3. So let's assume that our shape is something like this. Let's use blue, okay, for the shape right here, okay, that we want to stimulate. So let's assume that the shape is something like this. Okay, in all 3 cases. So to continue, just to clarify, reversible competitive antagonists frequently unbind and rebind to the receptors. All right. and an agonist can replace the antagonist while it's unbound, which allows the antagonist effects to be overcome with the addition of more agonists. Irreversible competitive antagonists, which are called sometimes non-competitive antagonists, also bind to the site where an agonist binds, but unbind from the receptor very slowly, if at all, really. And they can reduce the maximal effect of an agonist has, regardless of how much an agonist is present. Of course, some drugs might also bind to a receptor at a completely different site from where an agonist binds and influence the function of the receptor. These chemicals, these drugs, are often called allosteric modulators and may increase or decrease what? They increase or decrease the likelihood of an agonist binding to a receptor, or reduce the effects of an agonist has where it does bind or activate the receptor on their own. So what happens here? In the first case, you have a full activation. In the second case, it's compromised, so you have a partial activation. And the third case, because the shape will not lead to any function, you have no activation whatsoever. All right, so let's continue. After this very brief explanation, you do understand how there is indeed a difference between something that, let's say, look like this and look like this, because the ultimate shape will determine the outcome. Now, I would like to invite you to see that more specifically with some example. In order to do that, I will ask my two wonderful assistants to demonstrate that to you. So without further ado, let's go to the lab. And here we are in our lab. Let me introduce you to Dr. Lucas and Dr. Adrian. Welcome, everybody. So what are we going to talk about today?
We're going to be talking about antagonists, agonists, and partial agonists.
That's fantastic. Wow, good job. So how are we going to do that? Do you have any idea?
We're going to be demonstrating with Legos.
Cool. I love that. So let me see. Can I use one of those?
Yes.
Can I borrow one? All right. So let me see. Let's say if I'm giving you, let's see, what pieces do we have here? How about these two? Okay. How about maybe these two pieces right here? Okay. What can you do with it?
So, if you connect the pieces like this,
Yeah.
they can connect together,
Oh.
and that's agonist.
Yeah.
But if you take them apart and put them behind each other like this,
Yes.
this is antagonist.
Oh.
Because see, they break apart.
They don't bind,
They
huh?
don't bind.
Oh, I see.
And if you have something like this is partial agonist. Because it works in some way, but it also kind of doesn't work.
All right, Adrian, so how about this? What is this? Uh-huh. Why don't you try to see if it works?
So as we can see, my brother is trying to work the lock. And then he works it.
Adrian, does this work?
Yes.
So aside from destroying the lab,
This is an example of agonist.
oh,
Agonist is something that works.
uh-huh.
And
That makes sense.
This would be an example of antagonist. This key. Now, Adrian, what I need you to do is try out this key. Now, as you can see, he's trying hard. The key doesn't go in. And even when the key does go in, it doesn't lock. This
So-
is the example of antagonist.
Oh, so an agonist is something that attaches to the lock, enters the lock, and then makes the lock work. And an antagonist is something that even if you try, won't open, right?
Yes.
Oh,
See, like
I see.
now my brother's using the right lock. As you can see, I'll bring it up close. I'll bring it up close. The lock is unlocked.
Uh-huh.
But when you use the other key,
Thank you, Adrian, for the
other
demonstration.
key, Now we're letting him use it and see if he can lock it. Now, as you can see from the lock, it did not, the lock did not work.
Uh-huh. That makes sense. Well, thank you very much. Adrian, can you try to find other pieces of Lego to see if they match?
You can find whatever pieces you want, and we'll test it out if they're agonists, partial agonists, or antagonists. These two pieces, my brother just shows you when we put it up to the camera. Two Lego figure body parts. Now my brother's going to see if they work. As we can see,
good job.
My brother put them together.
Well done, Adrian.
This is called agonist, and my brother is going to do a demonstration of antagonist. Please, can you take it off?
Yes, that's right.
Antagonist is something that does not work. So try putting it together. Try putting it together a different way, I said. Like this. See, my brother tried putting it in the armhole right here. So as you can see, it does not work because the hole is not big enough. Now that is antagonist. Antagonist, once again, is something that does not work.
And one more try. What if I were to use these two? How about something like this and something like this? Adam, what do you think?
As we can see, my brother found a way. This is agonist. My brother found a way to connect these two pieces on. Now this was partial agonist because it doesn't go on that well. And it's partial agonist because this is not Lego and this is. So he got it on well enough that it's at least partial agonist.
Right. And how about this pen, Adrian? What do you think? So it works. So how do we call that? Because you have an idea?
It's called the Acad. It starts with an A. Let's see if you can remember.
Yes. Bravo, Adrian. Yes, an agonist.
Okay.
Well, that was a really good experiment. So I want to thank you both again for this wonderful demonstration to the class. Thank you, Dr. Lucas. Thank you, Dr. Adrian.
Thank you, Dr. Acad.
Wonderful. So, shall we say bye to the students?
3, 2, 1.
Scientists! Here we are again. I hope you enjoyed this little demonstration. So that kind of explained a little bit basic psychopharmacology for this Intro to Psychology course. I hope you enjoyed that little demonstration, but before I let you go, there are a few more things I want to say. And among these things, of course, some basic descriptors, definitions, labels. So again, pharmacology, as we have seen, in general is the study of drugs, medication, and their effect on life processes. And pharmacotherapeutics is the medical science which is concerned with the use of drugs in the treatment of disease. As we mentioned before, the concept of disease, illness, disorder, etc., is connected to both neuroscientific factors, biological factors, but also to social and cultural frameworks. And this is very important, as we have seen when we discuss the history of psychology and psychiatry and the use of the DSM, the ICD. To continue, when we think about pharmacodynamics, okay, this is the study of what, as the name implies, this movement, pharmacology on one side and dynamics on the other side, the biochemical and physiological effects of this medication, these drugs, and their mechanisms of action. When we talk about psychology as a science, we think about mechanisms and processes. So we have to observe them, we have to monitor them, and we have to be able to replicate them. What are the 4 factors that affect pharmacodynamics? They are polarity, size, or binding abilities of the drug, the fluid status of the patient, hydration and protein concentration, or the body habitus of the individuals. Okay, those are all very important factors. Let's continue, because when we're talking about psychopharmacology, we also need to understand how the transmission of those chemicals occurs. In week 1, 2, and 3, we briefly discussed what the neural underpinnings were. So we should remember the synapse, the synaptic cleft, the action potential, the axon, the dendrites, the cell body, etc., etc. But going deeper, we had to think about neurotransmitters. So transmitter substances are synthesized, stored, released, and terminated, susceptible to drug manipulation. As we have seen in the little demonstration earlier, we have direct agonist, which is a drug that binds to and activate a receptor. An antagonist, a drug that binds to but does not activate a receptor. And indirect antagonists, drugs that interfere with the normal action of a neurotransmitter without binding to its receptor site. In terms of the activity in general, a good way to remember there is that agonists increase and antagonists decrease. As we have seen in this lecture, the synaptic transmission has to do with a direct observable effect. And if you can see here the difference between agonists in the left side of your monitor and antagonists on the right side of the monitor, the ligands play an essential role. All right, so as far as what we discussed earlier, to go back to pharmacokinetics, I want you to understand that there is absorption, there's distribution, and elimination. Since pharmacokinetics is the study of chemical substance, absorption, distribution with the body, and elimination, you need to understand that there are different ways to utilize medications. And we will see this in connection to medicine, but more specifically to nursing. So in terms of absorption of the medication, which really means the chemical, this depends on the route of administration. The slowest is oral and the fastest is intravenous and inhalation. We should not completely separate prescribed drugs from drugs in general, because it is essential to understand not just the interactions and the dangers, but the added dangers when a drug is utilized without medical supervision. Okay? Besides absorption, we have distribution, which depends on how soluble the drug molecule is in fat, which has to pass through membranes. We'll see that in a previous slide, right? And on the extent to which the drug binds to blood proteins, albumin. Finally, elimination is accomplished by excretion into urine and or by inactivation by enzymes in the liver, okay? Which is connected to how dangerous over time the drug is, and of course this is connected to toxicity level. Now, efficacy, efficiency, and effectiveness. What does it mean to understand the curve of dose and response? As you can see in this image, this curve, the DR curve, depicts the relation between drug dose and the magnitude of the drug effect. Okay, so it's not the drug alone, but also the effect of the drug over time. So drugs can have more than one effect. They can vary in effectiveness. They have different sites of action and different affinities for receptors. The effectiveness of a drug is considered relative to its safety. This, something I want you to remember, is the therapeutic index, which really varies, and that's precisely why the research keeps improving in terms of modulating all these parameters. Now, because I mentioned that there are different ways to absorb drugs in pharmacokinetic sense, I would like you to remember, possibly by heart, the 5 rights of medication use. Now, this is essential if one day you want to become a nurse or a physician, etc., but is essential to understand even from a general psychotherapeutic, psychological perspective, because you want to be able to understand the current state of affairs both physiologically and psychologically in regard to the patient you're treating. So what does it mean to understand the 5 rights of medication use? Not just for psychiatry, not just for pharmacological intervention in terms of psychological treatment, but in general, 5 rights, 5 R's means the right patient. You want to make sure that you give the drug to the right patient, okay, if you're a nurse or a physician. The right drug, the right time, the right dose, and the right route, okay? We mentioned oral as opposed to intravenous, for instance, okay? Now, this is important because medical errors and extra added dangers is essential to understand what the person is presenting with, okay? Also not to have false presupposition about diagnosis, okay? In general, you can see here on this slide on the top right, rapid absorption is equal or is related to high abuse potential, okay? The more rapid the absorption is, the higher chance for abuse you might observe, okay? So what are the routes of drug administration to the body? You have IV, intravenous, right, into a vein, which is rapid absorption. Intraperitoneal, IP, into the gut, which is used in our research in lab animals. Subcutaneous, SC, under the skin. Intramuscular, IM, into a muscle. Inhalation of the drug into the lungs. Topical, absorbed through the skin, or oral, via the mouth, okay? So those are the routes of drug administrations. Now, beside those 5 R's and the routes, what else can we say, since we're talking about pharmacology? Tolerance and sensitization. Repeat administration of a drug can alter its subsequent effectiveness. What does it mean to talk about tolerance? Tolerance is repeated drug administration as resulting in diminished drug effect or requires increased dosage to maintain constant effect. We will see that next week when we will talk about addiction, recovery, emotion, and stress, okay? How the drug effect is diminished in regard to the tolerance. Withdrawal effects are often the opposite of the drug effect and often accompanies tolerance. Very important because we learn, our body learns. Our body has this physiological intelligence when we are prescribing drugs or we just utilizing drugs. Tolerance can reflect decreased drug receptor binding or reduced postsynaptic action of the drug. And finally, sensitization, repeated drug administration results in heightened drug effectiveness. Okay? All right, next slides. As I mentioned multiple times, this is an intro course in psychology, so this is a brief list of medications, of psychotropic medications. You have antipsychotic, antidepressant, anxiolytics or sedatives, hypnotics, cognitive enhancers, psychostimulants, etc., etc. In the image, you have some description of receptors here. The one that you probably are very familiar with is SSRIs, like serotonin rehab inhibitors, even though SNRIs is somewhat popular with the general psychopharmacological understanding. And you have different type of receptors here, serotonergic, noradrenergic, etc. One quick things about cognitive enhancers, as much as we talk about nature versus nurture, you should never view medications as separate from the context, from learning perspective, from conditioning, from environment, etc. All right, now going back to the synapse, what are the presynaptic drug actions? Presynaptics autoreceptors regulate the amount of NT released from the axon terminal. Drugs that activate presynaptic autoreceptor reduce the amount of NT release, an antagonistic action. And then drugs that inactivate the presynaptic autoreceptors increase the amount of NT release, an agonistic action. Again, a different way to look at antagonists and agonists. Presynaptic heteroreceptors are sensitive to NT released by another neuron and can be inhibitory or facilitatory. All right, let's continue in our list here. Neurotransmitters binding to receptors produces either EPSPs or IPSPs. Glutamate produces EPSPs. GABA produces EPSPs. Neuromodulator alter the action of system of neurons that transmit information using either glutamate or GABA. Now you might wonder, whoa, what are all these acronyms? I don't understand a thing. So I want you to have a general overview of the types of neurotransmitters that I don't expect you to remember by heart this semester, but at least have a general understanding of the type and class of neurotransmitters. In order to do that, I added the slide that contains both the description, the label, as well as the biochemical structure of the neurotransmitter, just to have a general overview. Okay, and this is taken directly from the textbook, but it's just to have an overall understanding. Now, in terms of why do we study neurotransmitters? Well, because they affect our psychological and physiological health. What neurotransmitters should we remember? Well, I asked you to remember 4 or 5 already in week 4, okay? But this should serve as a general review. Now, in terms of the research, acetylcholine was one of the very first to be really studied in general from the perspective of medicine, one of the first to be discovered. And what does acetylcholine do? Well, it plays a major role in the peripheral nervous system because it's released by motor neurons and neurons of the autonomic nervous system, but it also plays an important role in the CNS, in the central nervous system, in maintaining cognitive function. Okay, so this is one of the most important things about acetylcholine. Damage to the cholinergic neurons of the central nervous system is associated with Alzheimer's disease, as we have seen. How about glutamate? Well, glutamate is the primary excitatory transmitter in the CNS. And so when you think about glutamate, you think about pumping, so to speak, or excitation, right? So what is the opposite, the major inhibitory transmitter? Well, it's the derivative gamma aminobutyric acid, or GABA, which is the acronym we just seen. What about glycine? It's another inhibitory neurotransmitter that's mainly found in the spinal cord. Okay. In terms of the chemistry, many of those neuromodulators are monoamines, for instance, dopamines. There are several dopamine pathways in the brain, and these neurotransmitters involved in many functions, for instance, motor control, reward, and reinforcement and motivation. We talked about dopamine when we discussed exercise and physical health for psychological well-being in general. How about noradrenaline, which, if you remember, is the same as norepinephrine? This is another monoamine, and is the primary neurotransmitter in the sympathetic nervous system, where it works on the activity of various organs in the body to control blood pressure, heart rate, liver function, etc., etc. How about another monoamine that's very popular, serotonin? We discussed serotonin when we talked about SSRIs. Neurons that use serotonin project to various parts of the nervous system, and as a result, serotonin is involved in sleep, in appetite, mood variation, memory, etc., etc. But it's also produced in the gastrointestinal tract in response to food. So in that sense, when a person is telling you trust your gut or having a gut feeling from a neuroscientific perspective, that makes a lot of sense. Serotonin is essential to understand gastrointestinal function. Okay, maybe another one that you should remember, just because it's very popular in general and in medicine in general, and also in terms of possible issue with self-medication, is histamine. Which is also a monoamine, and it plays a very important role in metabolism, right? So it regulates hormones, it plays a role in controlling the circadian rhythm, the sleep-wake cycle, as well as temperature, and so on and so forth. So this is just a list, but I want you to just have a general exposure to neurotransmitters. Now, in terms of what are the steps that neurotransmitters go through in order to be productive in neurotransmission. What is the step of neurotransmission? In this slide, you see there are 7 main steps: synthesis, storage, enzymatic destruction if not stored, exocytosis, termination of release via binding with other receptors, binding to receptors, and then inactivated. So as the previous examples with Lego blocks, okay, the postsynaptic receptor will receive this information. And depending on the structure and the function of both the chemicals and the receptor itself, that we might observe an activation of a specific modalities. Okay, so and this is how we understand that our thoughts, our emotions, and our action in general are directly affected by this neural underpinning. So we are also our chemistry. Okay. The next slides, it's the first slides on psychotropic medications. Again, there are so many that I don't want to give you the false impression that this module will cover them all. And in this list here, we have antidepressant, antipsychotic, stimulants, mood stabilizers, anti-anxiety, and anti-obsessive agents. The big caveat is that chemistry plays a major role in everything we experience in life, but it's always somewhat arbitrarily constructed to call a drug an anti-obsessive, okay, or an antidepressant. The drug itself follows chemistry. We experience changes in chemistry as emotions or as thoughts, but to label them is simply to help the medical community in best treating our patients depending on their issues they're having, okay? And of course, when we talk about treatment, okay, it's not enough to identify which chemicals the patient will benefit from, but also follow the patient over time to monitor for changes in behaviors, in perception, in mood, toxicity, possible issues. But in general, depending on the symptom severity, you have, for instance, a acute phase, okay, in which you have the response, right? Then depending on which medical issue and the disorder we're talking about, that you can view that like 3 months, okay, this is response, right? And then you might have a continuation phase, 6 to 12 months, okay? And then maintenance phase, which might be year long. And then you have, of course, remission and recovery as part of the 3 phases of treatment. Just does not mean that we should administer antidepressant the same way as we prescribe antipsychotic, okay? This is very, very different, but I just want to mention that there are different phases of treatment that are entirely predicated on all these elements: time, symptom severity, what type of chemistry we observe, and what type of behavioral response, cognitive response, and emotional response the patient displays. So, to simplify things, in the next slide, we see antipsychotic, okay, which are usually divided into typical antipsychotic or first generation antipsychotics, D2 receptor antagonists, atypical or second generation serotonin or dopamine antagonists, okay, and then require around 1 month for significant antipsychotic effect to be observed. I also want to show you here some adverse effect of antipsychotic receptor occupancy, okay. We mentioned a few like dopamine, histamine, and serotonin, okay, and what type of side effect or adverse effect we can observe: changes in weight, changes in memory, more or less sedation, changes in appetite, and some very concerning long-term problems such as tardive dyskinesia, sexual dysfunction, etc., etc. So this is just some of the example, okay? And of course, we need to understand that with great power, so to speak, comes great responsibility. The stronger a medication is, the more effective it is in the short run and in the long term, but also it comes with very often very strong adverse or very significant side effects. So when we talk about antipsychotic of the second generation in the next slide, we have to keep in mind a few things. First, positive symptoms are influenced significantly better than placebo and equally or more than by the classical antidopaminergic neuroleptics. Negative symptoms are reduced significantly better than by placebo or classical antidopaminergic neuroleptics. Affective symptoms are influenced better than by placebo or classical antidopaminergic neuroleptics, 4, they significantly reduce or prevent the cognitive impairment. The reduction is higher in comparison to classical anti-dopaminergic neuroleptics. The treatment-resistant patient with schizophrenia improves significantly better than the placebo, or at least equally as by clozapine. Maintenance treatment is more effective than maintenance on placebo, and at least as effective as maintenance on classical neuroleptics. So this is just a general overview about antipsychotic. One more thing about antipsychotic is that the label itself could also be viewed as quote unquote a downer, a calming effect, okay? Because psychosis, by definition, is displayed in the way we already observed last week, this enhancement, this active, overactive manifestation. So an antipsychotic will calm the system now. So that's a good way to look at it. What will be the opposite? Well, the opposite, as we can see in the next slide, will be antidepressant, right? So while antidepressants are labeled as such, and you think of depression first, they're also used for many other things. Some relate to depressive disturbances, which have to do with mood, but also physiological problems. They're also used for affective disorder, for OCD, for panic or eating disorders, for psychosomatic disorders, for PTSD. In some cases, for alcohol and drugs withdrawal symptoms, because again, they're stimulants, right? They're not neurochemically speaking, but they're adding to the perception, and to some extent for narcolepsy, neurosis, and pain syndrome. In this slide, we also see these overlapping circles, okay, with the mood at the center, okay, and you have dopamine, top left, with attention, pleasure, and motivation as associated outcomes. Norepinephrine with energy, alertness, and concentration. But there's an overlap with anxiety, where serotonin plays a major role in obsessions and in compulsions in general, the OCD. So there is an overlap. So looking at these chemicals is only part of the issue here, okay? And this is not something that we only know in modern times, in how can I say this, in positivistic or post Enlightenment empirical evidence-based science perspective. The connection between chemicals, substances, and mood and thought is something that we knew since time immemorial. You should remember some of the names that I mentioned in previous weeks. For instance, in the Persian, Arab, Islamic world, the name of Avicenna. In the ancient European world, for instance, Hippocrates or Galen. So the connection between chemicals and the way we feel, the way we think, is something that's been known to humanity for a very long time. Now we have more of a scientific understanding of the specific neurotransmitters that are responsible for that. So in terms of antidepressant, first generation antidepressant, the next slide shows some basic mechanism of action, okay? But there's also many side effects. Of course, the danger of intoxication is always there. There's a lot of interactions, and then you have to think about the effect over time. With depression, we often talk about 2 blue weeks, but then the prolonged effect should be observable if we take into account all of the above after 3 to 6 weeks. So in this little slide, you see some adverse side effects in terms of percentage of patients, okay, overall, and the specific differences, okay. Not all of them here. The green indicates placebo, okay, and then in blue you have fluoxetine, in red amitriptyline, and in yellow imipramine. You see that dry mouth plays a significant role in the percentage of patients experiencing that, but then you have some other strong effects. In fluoxetine, you see a very strong percentage experiencing nausea and nervousness. Again, this makes sense, right? Because we're talking about an antidepressant as something that makes you more active, more lively. So too much of it makes sense. It will enhance nervousness, okay? But then you find things such as, tryptylane, where beside dry mouth, you also have constipation, dizziness, headache, etc., etc. So you cannot really separate that fully, okay? And this is true also for tremor, because they play multiple things at once. So this is just something to keep in mind. Now, so beside all this, what other problem you might have? So you have problems at the level of heart, so cardiac problem, orthostatic hypertension, you have tachycardia, you have things that are related to urogenital issues, right? Anorgasmia, you might have ejaculation disorder, erectile dysfunction, priapism. But then you also have something that is definitely related to CNS, the central nervous system, as we can see here, dizziness, sedation, feeling lightheaded, feeling sleepy, feeling nervous, having headaches, having problems remember things, cognitive impairment, changes in appetite. And besides changes in appetite, you have straightforward gastrointestinal issues, as we can see, constipation, vomiting, diarrhea. But you also have autonomic nervous system issues. Dry mouth is definitely one of them. Urinary retention is another one. Blurred vision, sweating, etc. So it's important to monitor the patient over time with all of the psychotropic medications, okay? Now, in this other slide, we see types of antidepressant from the first, second, and third generation, okay? As I mentioned, the full clinical response between 6 and 8 weeks in major depression, up to 6 to 12 months in obsessive compulsive disorder, and some examples of prescription, okay? You have, again, another image here, another diagram of the class of medication and the name of the antidepressant, both generic and structure, as you can see in the US. So Celexa, Prozac, Luvox, Zoloft, etc., for SSRIs. For SNRIs, Cymbalta or Effexor are the most common one. Another ones that are very, very commonly prescribed is Wellbutrin or bupropion for norepinephrine, dopamine. So this is a general overview, but again, keep in mind that antidepressant is a label, and in the case of Wellbutrin, for instance, you find that in application in many, many other psychological disorders. Now, since antidepressants is one part of the curve or the spectrum, antipsychotic is the other one. In the next slide, we see mood stabilizer. Lithium is probably the oldest one in terms of the way it was prescribed, and there are other mood stabilizers that activate multiple things that affect both psychological response as physiological response. Think of gabapentin or topiramate, for instance. And because there are mood stabilizers, both up and down, they're used in treatment of bipolar, affective disorder, and similar conditions associated with impulsivity. Okay? And you have some description here of therapeutic levels. Again, please do not view these slides as prescription. Okay, I mentioned this many times. And then common side effects and very dangerous side effects. Okay, I will not read through the slide here, but you just have a general overview. Now, in terms of anxiolytics, benzodiazepines, very, very commonly prescribed. And again, you have to think of anxiety as an enhanced outcome. So an anxiolytic, something that makes you feel calmer, is by definition what can treat anxiety. The important note here is that there is a risk of dependence and withdrawal. Okay, like it's always there with all medications, and there's other medications as well. Cholinesterase inhibitors, for instance, donepezil, rivaroxamin, galantamine. I added here that Tacrone has been withdrawn, and there's something to be said that a lot of things we know nowadays might not be fully understood in the same way in 5 or 10 years from now. Every time we talk about psychopharmacology, we have to think about a constant evolution. So please don't take this as the last word, because the research keeps developing. So whether we're talking about potential side effects or adverse effects or specific dosage, things do change constantly, okay? Sympathomimetics like methylphenidate, dextroamphetamine, and anticholinergic agents such as proclidin and benztropine. Okay. Now, other dangerous problems and side effects, you might have hypertensive crisis associated with the old school MAOIs, neuroleptic malignant syndrome, serotonin syndrome, and agranulocytosis, which we observed that previously. So there's a lot of things to be said about this, but this is just an overview of psychopharmacology. And of course, we could view this in a broader sense. Drugs are pretty much anything that is chemically based. We could see that, and that's precisely why we need to understand that psychoactive drugs are not just what we prescribe, we as doctors, right? But everything can be viewed as a drug, both in a neuroscientific or chemical term, as well as in terms of the way people are exposed to them. So in your textbook, you do have a table 5.1, where you have a whole list of some psychoactive drugs, okay? I didn't want to include it in this slideshow because you can find this information as part of the first 15 slides here, but it's pretty much a repetition. So you have classes of drugs, type, common effects, and the possible effects, in this sense, not as side effects, but a result of abuse and addiction. But just to give you a general overview, among the things that people are very familiar with, coffee and alcohol, which we will discuss also next week when we will talk about addiction per se, or tobacco, right? Tobacco is a stimulant, just as coffee is a stimulant, and alcohol is a depressant, the same way as a tranquilizer is a depressant, Valium, for instance, or barbiturates, right? But then you have other type of stimulants that are extreme in the results of abuse or addiction. Think of amphetamines and methamphetamines or ecstasy, MDMA, right? Which will have common effects such as this elevated mood and raised metabolism, feeling present, alert, and wakeful. But then you have side effects such as being nervous and having headaches, but also having delusion, experiencing psychosis, and having heart damage, and of course physical death. The same way for cocaine, for instance. Cocaine is also a stimulant, right? So you would expect excitation, extreme energy, right? Energy and also suppression of appetite, which is also found in coffee, right? In caffeine. But then, because of this excitability element that cocaine has, you do have, all the above, but you experience anxiety, you have, paranoia, you might have, again, heart failure and heart damage and potential death as well, okay? So those things are better understood on a spectrum, okay? So you could say that caffeine is a smaller or lower level stimulant, right? Which will have this some overlap negative effects such as insomnia and restlessness, and then on top you have cocaine and you have amphetamines, etc., etc. But then you have things that are in between. So think of opiates, for instance. Opiates are essential to understand in our current opioid crisis to which unfortunately the medical community contribute to, at least in part. And by opiates we think of opium, of course the plant, that's where the name comes from, and we should take into account some historical and sociocultural elements, right? When we think about the history of the British Empire and China, for instance. But opiates is not just opium, it's heroin, right? Heroin, morphine, codeine, codone-based pain relievers. And of course, as the name imply, opiates will help with pain perception, relief of pain, but also create euphoria, right? And so that's more complicated. So you do have all the positive effects, besides the fact that you can over-rely on opiates, and that's part of the opioid crisis, but then you have very important negative effects such as convulsions, coma, physical problems, possibly death, and other problems you may have, such as this in-between psychoactive functions, psychedelic functions. So you have mild psychedelic, okay, marijuana, for instance, where you do have some of the elements you can find in pain relief mechanisms, right? You have relaxation, but then you have very significant side effects such as reduced ability to store new memories. You have issues such as lung damage, lung irritation, right? And very, very important psychosis-related elements, something that unfortunately in the United States is not well discussed as it is elsewhere, the negative effects of marijuana. And there's a big controversy because as I mentioned multiple times, just because something is legal, it doesn't make it good for you, right? So it's always something to keep in mind. Granted, marijuana is a mild psychedelic, nor as strong as strong psychedelics such as psilocybin, mescaline, LSD, etc., salvia divinorum, right? But it's nevertheless quite important to understand the physiological reaction, okay? And even with these strong psychedelics, it depends on the drugs. You do have this relaxation elements or separation from everyday perception, which can also result in psychosis and paranoia and hallucination and visions and detachment or dissociation. Okay, so when we study psychotropic medication, we should not be looking them from a only legal, social, moral perspective. We should stick to the science, to the chemistry, but because we're talking about human beings, we have to think of this as a whole, okay? So when we use drugs can be helpful if we know how to take them, but they're never the ultimate solution. When a person asks the question about what is the thing that makes us sick and what is the thing that makes us better or sets us on a healing path, the answer should always contain both nature and nurture. So yes, pharmacological intervention without psychotherapy is to a very big extent not helpful at all, because you cannot substitute one for the other. And by the same token, you can also think of this as whatever is the underlying mechanism exists as a process. So we should not take psychopharmacology as a substitute for work, or even worse, we should not look at psychopharmacology as a way to change who we are as people. Everything is indeed the result of chemistry, neurotransmission, life experiences, personality traits, system of beliefs, examples in life, encounters, traumatic events, etc. We all are the composition of all these things. But understanding the chemistry that underlines our reaction, at the very least, gives us some higher level of insight in order to prevent stronger reaction that might be detrimental to our well-being. So if you combine what we discussed today with all the other elements that we previously related to, especially in the context of classical and operant conditioning in terms of what separates the stimulus from the response, then you'll be much better equipped to, first of all, understand yourself and your reaction much better, but also to help others, because you will be able to hopefully separate yourself from the emotionally charged overreaction you might have toward a problem, a situation, or a person. So that will be it for week 9. Of course, as I mentioned before, talking about psychopharmacology could take long time because this is just an intro. But I hope that at the very least now you have a bit of a bigger picture in terms of what's happening within us. The other thing I want to mention is that starting week 10 and to some extent week 11 as well, we will dig a little more deeper into what makes us who we are, and we will talk about developmental aspects, personality aspects, including personality tests, and overall psychotherapy. You might wonder why I waited so long to discuss psychotherapy in a course in psychology. And the main reason why I wanted to wait is because if psychotherapy is the most important area of psychology when we talk about clinical intervention to help others, it's also one of such areas that could also lead to further problems. We talked a little bit about Freud and some negative outcomes of certain psychoanalytic applications. And so if we start from science, and by science I mean in this context, pharmacology, chemistry, neurobiology, then we start from a more basic and objectively observable facts. Once we have that in juxtaposition and combination to neuroanatomy, pathophysiology, etc., then we are much better equipped to understand how all of this will impact mental health disorders. And that's precisely why, beside the diagnostic tools that we examined last week, once you study today's lecture, you'll be in a much better place to understand what we will be covering in week 10 and 11. Thank you very much for your attention. I will see you all next week. Reach out to me if you have any questions or comments. Bye-bye.